The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast. Well, greetings and welcome to our LymphCast show, believe it or not, episode 25 tonight. We're glad you're with us on video or audio or both. Let's go ahead and meet our panel, and we'll get into tonight's discussion right away. From New York, RVT, Jacqueline Sasek. Greetings, Jacqueline. How are you doing today?
I'm doing well, thank you.
All right, good to have you here. From California, Dr. Emily Iker. Greetings, Dr. Iker. How are you?
Thank you very much. Nice to see all of you.
You too. And from New Jersey, the creator, the founder, and the owner of VitaSupport MD, makers of Vein Formula 1000, Lymphatic Formula 1000, physician and surgeon, Dr. John A. Chuback, also the creator of this show. Greetings, Dr. Chuback. How are you, sir?
Doing well, Paul. Thanks. Great seeing you again. Looking forward to a great discussion.
You too. Can you believe it? We're a quarter of a century into the LymphCast. How about that?
25 episodes.
That's right.
Fortunately, we're not making one a year, but sometimes it feels that way.
That's right. That's a pretty good milestone. Let's meet.
Good.
That's right. Let's meet from Arizona, although she's not in Arizona tonight, but Dr. Monica Gloviczki. Greetings, Dr. Gloviczki. How are you?
Hi, thank you for having me. And indeed, this time is direct from Miami.
That's right. It looks nice over there.
Florida, attending the Venus meeting. And without further delaying, I will welcome our very special distinguished guest, Professor Dietzek Allen, from who is Linda and Stephen Cohen endowed chair in vascular surgery and at Danbury Hospital, and a clinical professor of surgery for the University of Vermont. I would especially welcome Professor Dietzek because we are in the kind of vein moment right now. And Professor Dietzek, who is a former president of the Society for Clinical Vascular Surgery, is also one of the very first who participated in the endovascular revolution for venous disease. So welcome, Alan, and we are looking forward to our discussion today around the venous disease.
Thank you, Monica, and thank you, Dr. Chuback. I appreciate the invitation and the opportunity.
So maybe, Alan, should we start? With the whole story, how it went to the clinical practice, the whole idea not to strip the vein, but to try to do something from inside and something minimally invasive and so much better for the patient.
Yeah, it's a fascinating how that was developed and implemented to have this minimally invasive procedure finally address what affects more people than any other vascular disease. In excess of 25 million people in the United States have venous disease, as you all know. And prior to the endovenous procedures, we performed a rather brutal operation that when, some of our older patients, when we discuss stripping and ligation, they break out in a cold sweat, remembering what that was like, or a relative that had the procedure where you'd make an incision at the groin and the ankle and take a long piece of plastic wire and yank it out and then make some very large, very non-aesthetic incisions and remove the varicose veins. So now, you can do a 20-minute procedure where you can introduce a catheter that heats by either laser or by radio frequency and close the vein in the whole procedure in less than 20 minutes. I think what's really made the major change, other than that technology itself, is the fact that we now have a way of anesthetizing the patients using local anesthesia, tumescent anesthetic, which when I was a resident was never talked about, and I don't think it was ever done, where you have a dilute lidocaine mixture that you inject into a patient with up to 700 cc's of fluid, and that's the so-called upper limit in a 70-kilogram person, but in fact you can even use more if you had to. But it allows you to do a lot of different procedures, phlebectomy, the endovenous ablations, as well as other operations in the office setting, without having to administer general or IV sedation anesthetic. And I think that's revolutionized the treatment of this disease.
Well, that was certainly a true revolution. Now, maybe for our audience, if you could walk us through the indications of this procedure and how in practice, what is the preparation, which patients are, they can have it as a procedure.
Well, I think, one of the great things about the procedures are that now they're easy to do, not associated with a lot of pain, walk in and out of an office. But one of the bad things about the procedure is that they're easy to do, and patients can walk in and out of an office, and the indications can sometimes be abused. The indications for closing the saphenous vein, which should not be taken lightly, are the presence of symptomatic varicose veins, would I consider be the least indication for it. And as high as, we have different clinical classes, as swelling with varicose veins, skin changes, which would be considered what we call C4A and B, and healed ulcers, venous ulcers, and open venous ulcers. So there's a variety of potential indications for the procedure. But what you don't want to see is patients having their saphenous veins closed for asymptomatic problems or just because there's insufficiency.
So what about the cosmetic requirement from the patient? What if this is only for cosmetic reason?
Well, that's a very good question, and it's a complicated answer because certainly no insurance is going to pay for a cosmetic procedure, at least not in 99% of cases in other fields. Yes, Dr. Iker.
I'm so sorry. I have to run to my patient, and I wish I will listen to you on YouTube. It's so exciting to hear you, and what an honor to have you here. But my duty calls on the other side as well. So I will listen to you on YouTube, and thank you so very much for joining us here today.
Thank you. Thank you for the kind words.
Everybody, sorry about that.
So I think that, certainly if a patient has severe venous and superficial venous insufficiency, they understand the consequences of the surgery, which are well explained. They have the opportunity to pay for the procedure out of pocket. There are very few patients that really want to do that. These are not inexpensive procedures. but that's the reality. If you want it done for cosmetic reasons, it should be paid out of pocket.
Okay, and you know, I'm aware of course, as everybody, about the some insurances asking for 3 months treatment with the compression therapy before going to the procedure. What do you think about it?
I think that's the other extreme, and I think that's, you know, my personal feeling about that is that it's somewhat absurd, especially in a young person. You know, if we're having symptoms as a result of their varicose veins, to ask somebody to wear compression stockings ostensibly for the rest of their life is not only more costly in the long run, but is not right. It's not fair. You know, we certainly don't ask, to my knowledge, if you have a acne that's symptomatic, no one asks for you to, you know, do something for a number of months that would delay treatment. Wearing a compression stocking is not going to alter the hemodynamics of the disease. It's not going to make your vein competent. Yeah. And when you stop wearing the stocking, you're going to have the symptoms. And then there's the whole issue of, what about in the summer months or the warmer months? What if you live in a warm environment? Do you really expect any patient, young or old, to wear compression in the heat? So it's really a delay tactic more than anything by the insurance industry to prevent patients from getting the care that they know that eventually they're going to get. There are a lot of other hoops they make patients jump through, which are disturbing. You know, especially when it comes to things like vein size and varicose vein size. And I mean, we wrote a paper a number of years ago that was published in JVS on small diameter veins producing the same kinds of symptoms that large diameter veins produce. And after treatment, the patients get the same degree of relief. And it's our practice, and it's not right or wrong, but our practice is we treat the saphenous vein and we do not do phlebectomy at the time of the procedure. And we started out doing that because we wanted to know which patients were really interested in getting symptom relief and which patients were looking to game the system and get a cosmetic relief. Also, the fact that somewhere around 30 to 40% of patients who get an endovenous ablation are going to get an adequate cosmetic result as well from the procedure. But what I was surprised to find is that most patients were unhappy enough with their symptoms to say, you know what? I don't care about the cosmetics. Close my vein because I don't want the symptoms anymore. And then if they had persistent varicose veins after the procedure that were symptomatic, we removed them.
Yeah.
But a lot of people end at the closure. They don't want any other procedures. They're just happy that they don't have the pain or the swelling.
Yeah. Well, that's certainly the main preoccupation. I can imagine for somebody not to have pain, of course, and it's very clear that once you treat the superficial venous segment, that it's involved in the whole process of the disease, and of course they are getting better. Now, are there any contraindications?
Contraindications to doing saphenous
to the procedure?
Well, there are. I'm trying to think of some of the real there are not a whole lot of true contraindications. Certainly hypercoagulable patients we're concerned about. We inform the patients that could be a higher risk of DVT. Patients who have very superficial saphenous veins, at least from a cosmetic perspective, might do better to have the vein removed surgically rather than with endovenous ablation. So, you know, even though we're not doing it for cosmetic purposes, we don't want to cause a cosmetic problem, an aesthetic problem, by closing the vein. I mean, that would certainly not be justified. But there are patients, especially older patients, even if the vein is superficial, that say, you know what, I really don't care about having a line down my leg. I do care about not having a general anesthetic, and I do care about having this procedure done as simply as possible and as quickly as possible. And so occasionally we'll do that in those patients. Other contraindications to the procedure, there used to be thought that if you had venous outflow problems or occlusions, that you would not close the saphenous vein if there were, let's say, a venous ulceration. But, you know, the SVS has produced guidelines and have shown that veins that over a certain diameter size, even in that circumstance, those patients would benefit from saphenous ablation. So there are very few true contraindications. I may not be thinking of one. John, you may be thinking of one that I'm just not thinking of right now. But there are not a ton of contraindications to the procedure.
No, I would agree.
John?
No, I would agree completely that those are cases where there's concern, but in both cases, you know, Alan is a very experienced surgeon, and I put myself in that category when it comes to venous disease. Those are common scenarios, both of the scenarios that he pointed out, thrombophilias of varying degrees and intensities, and there's overlap with the second category of patient, those who have had DVT in the past, have post-thrombotic syndrome, scarring, et cetera, et cetera. And yes, I think that we have gotten much more liberal in treating those patients, and touch wood with excellent results in almost all cases. The other area that I would actually bring up, which is another place where I have personally evolved in the last 20 years treating patients, is the patient with phlebolymphodema, where your phlebolymphodema is not necessarily the primary cause of your lymphedema. So in other words, patients with primary lymphedema who had a known long-standing history of primary lymphedema or secondary lymphedema to trauma, surgery, et cetera, who then developed venous insufficiency and looked like good candidates for treatment. Very early in my practice, because of our training, I'm a board-certified cardiovascular surgeon and also general surgeon. We were so paranoid to injure a patient or make their lymphedema worse, because we had heard all of the stories in our training about putting an IV in a patient, let's say, who had had breast cancer and lymph node dissection, drawing blood from that limb, even blood pressures in that limb. So very early on, that would be a third category that I can think of off the top of my head, that I was concerned about doing an endovenous ablation in a patient who had primary or secondary lymphedema not related to their venous insufficiency. But again, now with many years of experience and having grown more and more confident, I routinely treat those patients, and remarkably, they essentially all get better. I can say that I've never made anybody worse, and it still remains a concern every time I do it, quite frankly. But touch wood, I haven't made anybody worse. There are a few people, small number, who I would say were about the same in terms of their edema afterward, but most patients get significantly better. Alan, would you like to comment on your experience with that?
I feel the same way about those patients. It always makes me a little nervous. But I've done some in patients with lymphedema and have had some good results. But it's not frequent. I think one of the, I won't say contraindications, but just someone who I would not do this in. You know, a lot of times we'll get patients with lower extremity, just chronic lower extremity swelling. They don't have lymphedema. They're older. And I don't think that closing their saphenous veins will give them any kind of long-term benefit. And I often see these patients back, having been treated elsewhere, and they're swollen again. And now they may have some pain related to their procedure or something else, because whenever you touch a patient, there is the potential for harm. And I just don't think those patients get a lot of benefit unless there are associated varicose veins. But I've seen, unfortunately, too many patients with no varicose veins, just swelling, and I don't think they do very well with treatment.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
The thing I would say is that where I broke through on that over the years was in class 6 patients. There were people with venous stasis ulcers who had lymphedema and significant venous insufficiency. And even there, I tried hard for an extended period of time in those patients to heal them with debridement, compression, and non-surgical measures. And when they were incurable, that was the first few ablations I did in those lymphedema patients. And to my great joy, I must say, they healed and got better. So that's when I got a bit more lax and lenient in treating those patients when I felt that I could be helpful. But I agree with Alan, there are many whom I still treat conservatively if I don't think I can help them with the venous procedure, and if I don't think that, again, what we call the juice to squeeze ratio is there, the risk reward. You have to, and that comes with experience as a surgeon. And that's for our listeners who are non-physicians and physicians, but especially our non-physicians listening. That's why we always say on this program how important it is to find a surgeon and specialist in this area who is well-trained and highly experienced, because mistakes can be made, and some are technical, but more commonly it's, I think, in judgment.
What about the pregnancy and varicose veins?
Well, are you talking about the standard pregnant patient who comes in with new varicose
Absolutely.
symptoms?
Yes.
Yeah,
Yes.
I would certainly not treat those patients during pregnancy for a variety of reasons, but not the least of which is that many of those symptoms, I've seen everything from horrible varicose veins with pain. And I usually tell I usually prescribe them pregnancy compression stockings, pantyhose. But I've seen patients who, after their pregnancy, all the varicose veins have resolved and they no longer have symptoms. And I've seen other patients come back and they have persistent varicose veins, usually not as bad as they were during pregnancy. But I would not treat a patient for venous insufficiency or varicose veins during pregnancy.
Agreed. And I would just add there that my experience has been, and I'd love to hear Alan's input there too, first and second pregnancies, many times there can be a complete resolution to normalcy after the pregnancy, especially in smaller ladies who are carrying low and so forth. But after third and fourth pregnancies, that's where things tend to not resolve as completely. The other, I would mention one product that I've come to know over the years, because Alan mentioned the pregnancy pantyhose. Again, I have nothing to do with this company, but there's a very good device or garment called the Fembrace, and they can find that online if patients are listening, when you need vaginal and vulvar support. It's a very, very good garment, and I've had great success with that over the years.
Now I would like Alan maybe to explain what type of the endovenous treatment do we have in the current time?
Well, it seems that they keep increasing in number. So we have the thermal procedures, which means that they close the vein by means of generating heat. One is, of course, the laser, and there are a whole host of different laser fibers and wavelengths. And there are early on in particular, I remember when I was first doing the endovenous RF ablation, there were others like Lowell Kabnick and such who could give a whole talk on one wavelength, one fiber wavelength. So, so there are those. I think that's been perfected a little bit more than it was then. So you have those two for the thermal ablations, RF and laser. Then you have the chemical or non-thermal ablations, where you don't have to give tumescent anesthesia. So you have to give tumescent anesthesia, what I was talking about before, the dilute anesthetic, for a few reasons. One, and most importantly, it acts as a heat sink around the vein so that the surrounding tissues don't get injured. So when you, the laser fibers generate so much heat that, you know, I think some of them generate heat up to 1,000 degrees that they can perforate the vein. And so you have to have a heat sink. And likewise, with a radio frequency ablation, the standard temperature is about 120 degrees Celsius or 20 degrees Celsius above boiling. So these are hot. So you have to have a heat sink around them. Number two is to cause compression of the vein onto the catheter, whether it be a laser fiber or whether it be the RF. So those are the tumescent procedures, and it requires the injection of this volume of fluid with the lidocaine, dilute fluid with lidocaine, and it requires multiple injections. They're not terribly painful, but there are patients who understandably don't like to get injections. Then there's the non-thermal, as I said, the chemical. So there's one called Claravane, which combines a mechanical process of a little hook spinning inside the vein to damage the inside of the vein, the intima, combined with a chemical, such as a sclerosant or a detergent. The products we use when we do the little spider veins is really the most common are the detergents, which injure the inside of the vein and cause it to scar down. Interestingly, it was probably one of the biggest mistakes I ever made was the person who developed the Claravane procedures, a guy named Michael Tall, who was an interventional radiologist at Yale. And he actually came to me back in around 2003. And he said, listen, I developed this new thing, and I heard you do a lot of endovenous procedures. I'd love you to take a look at this and maybe do a trial. And so I, do a fair amount of research, and I looked at the product and I said, are you crazy? All this is going to do is cause phlebitis. And how wrong that was, of course, he then moved on to Steve Elias, who did the first trial with the Claravane, and then got to speak about it for about 5 to 10 years afterwards. Although we did do the first FDA-approved Claravane procedure here at Danbury. In any case, the other procedures are the glue, cyanoacrylate, which is also non-thermal. So you inject the glue, and that can seal the vein. The difficulty with that, or the potential problems with that, or that it can cause an allergic reaction. And that's very problematic, especially if you didn't know you were going to have an allergic reaction, and now you have this, this mass of glue inside your saphenous vein. It's very uncommon to have that allergic reaction, but if you have it, the vein has to be excised, usually. That's the other, some people are not happy with the fact that you will always have this chemical within your vein. Does it have any long-term effects? No one knows, probably not. I don't know of any reported long-term effects other than allergic reactions. The other one is microfoam, which is a compounded sclerosant and nitrogen, whereas before we did it ourselves in our office, mixing, the oxygen with the sclerosant, and it forms a bubble mixture, and the purpose of that is because those little bubbles have a great deal of surface area, and so theoretically you get a much more complete contact with the vein wall and a better response in narrowing down. However, it goes back to liquid form very quickly. Additionally, there were some reports of the air getting into the, if you had a patent foraminal volley in the heart, a hole in the heart, John, you could probably speak to this better than me, but that if anything got through that hole, it could go right up into the brain and cause neurological symptoms, and even the very, very rare episode of a mini stroke or a stroke. With nitrogen, that is, I don't think there have been any reported episodes of that. And so this compounded mixture made in a factory stays in that foamed state for much longer. We've used it. The problem we've had with it is that we found a much increased incidence of DVT because the solution can get out into the little tributary veins and cause those to, and if it goes into the deep system, can cause some DVT. I don't know if I'm leaving anything out. Does that about cover it? I believe it does.
I think that about covers it. Yeah, I would comment about your PFO question. Again, as we grow and progress as surgeons, and they call it the practice of medicine, the practice of surgery. As a cardiac surgeon, when I started doing veins, I was still doing open heart here in northern New Jersey. It was sort of an add-on to our cardiac practice because, as you know, open heart procedures, the volume was massively devastated by interventional cardiologists and angioplasty and stents. So we were looking for some ways to expand the practice. And Ron Bush, who you know very well, was a cardiac surgeon, and he was one of the early educators with Dornier and so forth, with one of the laser systems. And I was very, very slow to adopt foam injection because I had spent so many years de-airing hearts. I was so paranoid about one bubble in the heart. And then, early days, I think it was Nick Morrison or one of the guys presented this echocardiogram, when you injected this foam in the leg, and the entire right side of the heart was just filled with foam. And I said to myself, my goodness, if somebody has a PFO, you're going to kill somebody. I mean, you're going to give them a stroke in no time. When they say maybe 30% of people walking around are walking around with undetected PFOs. Now, generally, you don't have a right to left shunt, so you're protected in that way. But still, there's a hole in the heart in as many of 3 out of 10 people. So I was quite, resistant to doing that. And then little by little over time I did. And as Alan said, I started with the air compounded in the office, just using room air, and then later compounded with the CO2 system. And now, of course, we have Varithena and these other FDA approved things. But fortunately, most of us have had very, very little problem having now injected thousands of patients as we became more and more comfortable with it. But there is that potential, and I think Alan raises another, and we're not here to criticize or to promote or bash anybody's products, any company, et cetera. But with the glue, that was always, it's something that I have not used because from the very beginning, that was one of my apprehensions that a foreign body would be left behind inside of the body. And I always tell other surgeons, when I'm getting dressed in the morning, the TV tends to be on this program. It's a big group of attorneys saying, have you ever done a hernia repair with mesh? Because have you, or not have you ever done it? Have you had a hernia repair with mesh? Do you have mesh inside of your body? Because mesh is obviously very, very dangerous, et cetera. Or have you ever had a vena cava filter placed and so forth? And I'm sitting, you think to myself, my God, how many vena cava filters have I put in? So when I started seeing those commercials, I decided the last thing I want to do is leave something that is non-absorbable behind forever. And I think Alan pointed that out very well, what some of those potential problems could be, not only now, but 10 and 15 and 20 years from now. So all great points.
I would like to also to touch some other side of this topic. As a scientist and researcher, I'm always interested on the pre launching phase of anything like device or procedure. And I would like to ask Professor Dietzek, so what are the requirements here in the United States to have the procedure admitted by the insurance company, by scientific societies, and ready to go in normal clinical practice?
It really depends upon the insurance provider, because they all have different cut points for, what they will and will not approve for endovenous ablation, or for any kind of ablation, whether it be chemical or thermal.
Another thing which really makes no sense, I'm sure you agree, Alan. I mean, there's a body of science out there and there are accepted standards. Why every insurance company and even different policies within the same company have different guidelines continues to baffle me.
Yeah, the local carrier may decide that, as Dr. Chuback says, that, the local carrier may say, we don't accept Medicare policy. We don't accept the policies of our other local carriers in the same insurance company, that, we have different criteria. So it is, at this point, just a crazy system. And, they'll stand behind their board that will review the literature, so-called review the literature. You don't know whether they're interpreting the literature properly. You don't know how old the literature is or when the last time they did a review. And my favorite answer when I call, one of the regional or local directors, medical directors, to get an approval on something that's been turned down, is I'll say, here are the papers for this. And they'll say, well, write us an appeal letter. Tell us what that information is. And at our next meeting, we'll review it. And I'll say, well, when's your next meeting? And they'll say, well, wait, we have one in 6 months. And then if it gets reviewed, which will take probably another 6 months, and then to change, in the meantime, there's a patient waiting for a procedure or waiting to have something done to help them. So it's a very frustrating system right now, very frustrating. Part of the reason for that is because there's a lot of abuse. So on the one hand, if you're doing the right thing, you're frustrated by the fact that, you're trying to do things to help patients, and you would expect that if you explain it and you have a justification for it, you'll be approved. On the other hand, you have others that are maybe not being honest about what they're sending into the insurance company, and so they're very concerned about that. So they're trying to control costs, but sometimes at the expense of a patient treatment.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Of the devices in itself, do you have strict policy as far as the device that you will use in the clinical practice? Is that controlled like the drug by FDA?
Well, they're in order, it's considered a medical device, so it has to be approved by the FDA. There is a little bit, there's this gray zone of reusing radiofrequency catheters or laser fibers. There are two companies now that make radiofrequency catheters, two very similar. One is Venus or the Medtronic product, VenaFit or whatever, it's VenaFit, which was really the granddaddy of radiofrequency ablation. And now there's something called Venclose, which is a very similar product but different, which cannot be reused. The prior Medtronic product, which was originally called Venous Closure Fast, was apparently it can be re-sterilized. And there's this gray zone as to whether that's, the FDA doesn't have a comment on whether it's approved or not approved, but somehow it can be used. So you can get the catheters much cheaper. I don't use re-sterilized vein products, but that is the only issue where there's some gray zone there. But other products, all these other devices went through years of testing before they came to market. The Verithena,
okay. So this is
the glue, the VenaSeal, Claravane, they all had to go through years. And that's another part of this insurance problem. Not, even though they're all FDA approved, not all insurance companies will allow you to use them. They feel that in some instances, they'll approve a radiofrequency and they won't approve a VenaSeal, a glue procedure. Or they'll approve a VenaSeal and they won't approve a Claravane, which is the chemical mechanical. There's no rhyme or reason to it.
Yeah, well, it becomes a moving target, and it makes it impossible for our staffs to do their job of pre-authorization, pre-certification, et cetera. And the industry is savvy to that. So they make it a moving target. They make it as complex as possible because that gives them the most options for denials. And really, I think to be concise with our language, it's not that the insurance companies don't allow us to do this or that or use this or use that. That's to our judgment. It's just whether or not they're going to reimburse for it. You can treat the patient in any way that you want, but then they'll say that this is not covered. You're not being paid. And as Dr. Dietzek pointed out earlier, passing that unpaid bill along to the patient, which can be a very, very large bill, after the treatment of significant disease, does not go over well. And many patients are clearly not in a position to pay such an enormous bill. So it becomes a huge part of all of our practices to work very closely with every single insurance company and the policies and so forth, and dot every I and cross every T prior to treatment, so that we know that the patient's care is going to be paid for. And that's a very important part of it that none of us really trained for in medical school, but need to be, educated on now, because otherwise it becomes impossible really to practice.
Yeah.
Yes. Now I would like you to discuss a little bit, what happens after intervention. Once you successfully remove or treated varicose veins, what is happening with the patient? Do you have any control? Do you ask patient to come, let's say, 3 months later or 1 year later? What is happening?
That's a very good question, Monica. Our practice is we duplex all the patients, usually within 72 hours, to rule out the possibility of DVT. Now, not everyone does that, and I don't know that it's necessary. We used to be very concerned about the risk of DVT. Some folks have shown that it's better to duplex them at 1 week. Some people feel that you don't have to duplex them at all. So it's just our practice. So our practice is we do it at 3 days. I sleep better at night if I know that at 3 days there's no evidence of DVT, or the whole, I won't get into the whole EHIT thing, but a true DVT. Then we like to see them again in a month, to rescan them, make sure the vein is closed, make sure the patient's happy, and that's usually it. I got to tell you that a fair number of patients don't come back in a month, and we've tried doing the 1 year follow-up. Most of them won't come back, especially if they're happy. They won't come back in a year, and if they're not happy, they've probably gone to someone else. So it's hard to justify bringing them back at a year if they don't have any new problems. But I'm not saying that's the right thing to do. I mean, every practice has its own way of handling things, but I do think you need some follow-up. I don't think you can just treat a patient and say, take it easy and hope it works out. And then there are the patients that, have either complications or perceived complications or findings they didn't expect. You need to deal with those.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
We follow our patients typically 48 to 72 hours after. And my training and all of our training informs how we practice medicine and surgery. But for me, again, as a surgeon, it would be inconceivable for me to say, put in a chest tube for a patient with a pneumothorax or pleural effusion and not get a postoperative chest x-ray to see where the tube is. Even if I have lots of clinical signs from the pneumovac that it's where it should be, we get a chest x-ray. By the same token, when I take the tube out, I wouldn't consider not getting a post-removal x-ray to make sure. Now, most of those patients are going to do just fine without that x-ray, but we practice medicine in America. It's a highly litigious situation. And the ultimate question comes, what would you want? If I had an endovenous ablation, I would certainly want a post-ablation scan for me, for my wife, for my mother. I want to know, do I have an extension up into my femoral? How big is it? Do I have, an extension through a mid-thigh perforator that nobody was really even aware was there in my mid-femoral vein? If you practice long enough, you're going to see all of these things, some scarier than others. The other side of it, as the physician, as Dr. Dietzek pointed out, the more foam we use, the more Varithena we do, et cetera, and Jackie, who was my lead tech and my director for years in my program, knows one of the greatest nuisances we deal with is the patient who has a beautiful procedure, except they have a small PTV DVT after the procedure that you really know is not going to do them any harm whatsoever. They really don't need to be anticoagulated, but the science is not clear on that. It's a 50-50. And we also live in, a free society where the patient has a right to know what's going on in their body, and you have to inform every single one of them that you have a blood clot, a DVT. And every time you have to have that discussion, which has become more frequent with the greater use of foam, it's not an easy discussion. Nobody loves to hear that they have a blood clot. Nobody sees that as good news and whatever reassurance. So some patients are going to insist on being anticoagulated. Some patients are going to insist on not being anticoagulated. But that follow-up scan is not all roses and peaches and cream either, because you do find things occasionally that clinically you don't believe as an experienced surgeon are material, but you also can't keep it a secret or exclude it from the patient's medical record. So these are all the balls that we juggle every day.
And for our audience, I would like to clarify maybe all these notions of EHIT, DVT. What are the differences? Please formulate this, because I'm sure that the most of our listener will not know.
So you mean about what the
EHIT, the difference between EHIT and DVT?
Yeah. So because of the way thermal ablation works, there's something called forward heating. So we always try to keep the catheter tip a minimum of 2 to 3 centimeters. I would say 3 centimeters or more from the saphenofemoral junction. And that's because that catheter, whether it be a laser fiber or RF, is very hot, and it causes coagulation of the blood cells and injury to the intima inside of the vein. And it does so not just at where the catheter ends, but it's forward of that. So it's called forward heating. And that can cause a clot. But what we found over time with a lot of experience, that clot that you get usually from the thermal ablation is not the type of fresh acute thrombus you would see in your typical DVT. And so it doesn't require any treatment. And often, most often, almost always, it resolves on its own. Now, sometimes that clot can extend to the saphenofemoral junction, and sometimes that can become involved with acute clot. And so there are different gradations of the so-called EHIT, 1 through 5, as described by Lowell Cavanick. And we see it so infrequently at this point that I can't remember the last time I had to treat an EHIT patient with anticoagulation. But once it gets beyond a half a centimeter into the lumen of the common femoral vein, you're kind of obliged to treat the patient with anticoagulation because of the concern that now you could have a DVT in a major vein or on the walls of the vein, which can propagate and cause a pulmonary embolism. And that's really the concern. It's not just the DVT itself, because the local effect of this kind of DVT is really kind of minimal. It's the concern that this could propagate into the deep veins, and then that could break off and go to the lungs, which could be have a great deal of morbidity and even mortality. That said, the mortality from these procedures is exceedingly low. I think it's something like 1 in a million, something ridiculously low, very, very low. Nevertheless, you don't want a patient to have that problem.
That's for sure. Yeah, that is certain. And what is the percentage of patient in whom you observe this EHIT?
We used to observe it much more frequently when we had, at least I did, using radiofrequency, when the catheter was within 2 centimeters of the saphenofemoral junction and the superficial epigastric vein. You used to keep it right beyond that point. Now that I go 3 centimeters or more, 3 to 4 centimeters distal to that saphenofemoral junction, we just rarely see it anymore. Much less than 1 in 100.
Agreed. And I think that
another question.
I was going to say, I agree.
Yeah.
And I think that was the number we all used to quote early on, was roughly 1 in 100, but it wouldn't be close to that now. And if one of our physician listeners is seeing, a higher percentage than that, I totally agree with Dr. Dietzek. I think it's a fairly simple solution, which is to back that catheter off a bit. It is not necessary from a hemodynamic and clinical point of view to have that vein closed flush to the junction. You're going to reduce the hydrostatic pressure in that system dramatically, even if you're a few centimeters back. So if there's a small stump proximally that remains open with flow through the superficial epigastric, that's a beautiful thing. That's not something you need to concern yourself with.
Another question that I would have for both of you: what is the longest follow-up that we have for those techniques? Is that within 2 years, 5 years, 10 years? How long? The follow-up went in during the at least during the studies done with these procedures?
Yeah, we have at least 5 years for the RF procedures, and those studies are old at this point. There is going to be a certain degree of recurrence. I think with the newer technology for RF and even with laser, you don't see a lot of patients recanalize their primary vein. You may see a segment of recanalization, but they're very effective in destroying the vein because the catheters are so hot. But that doesn't mean you can't get recurrent varicose veins. And so there are many things that can cause recurrent varicose veins, and such as new axial veins become more prominent and incompetent, such as the accessory veins, anterior, posterior, and depending upon where in the leg you've treated the first time, whether it be small saphenous vein, great saphenous vein, but you will get recurrences. But unlike the initial devices, where the recurrences could sometimes be as a result of the vein in reopening, you don't see that much anymore. At least I don't. I can't remember the last time one of our techs came to me and said, you know what, that vein you treated is completely open. It didn't work, or you just don't see that anymore. Whereas with the initial radio frequency devices, that was not uncommon.
Yeah,
Wow.
and I think that especially for larger veins, thermal ablation is still superior as opposed to the Varithena and even compounded foam, et cetera, that you might use for various circumstances. You're going to see greater rates of recanalization if you don't use heat in big veins. I don't think there's any question about that. But you could disagree.
Well,
Dietzek.
No, I think that's absolutely true. I think that the even large veins can be treated with RF or laser that I don't think you can treat with the other products and get a good result.
And for the end, I have just a question for Professor Dietzek. Do you have any experience with the perioperative usage of the micronized flavonoids?
Some experience, mainly because of you, Monica.
Yes, I know. That's why I wanted to have your comments, because you had the opportunity to see the effect in your patients.
I think they can be very helpful. I think they can be very helpful in reducing symptomatology and swelling, and so yes.
Yeah, I think a couple of the areas that you should really consider that the data really stands strongly behind. In your class 6 patients, I think it helps large and long-standing ulcers to heal more completely and faster. And then the other place where I've seen a lot of improvement in my practice in implementing the MPFF is in the post-thrombotic syndrome patients who you've done everything else that you can for them with compression, et cetera. And it seems that anti-inflammatory, antioxidant effect really is very, very helpful for some of those folks as well.
John, I think that we should wrap this very exciting discussion and review on all varicose veins procedures with our distinguished Professor Dietzek. And would you like to make some comments for the end?
Yes, thank you so much, Monica, as always, for inviting one of your esteemed colleagues. It's always, I have not had the pleasure of meeting Professor Dietzek in the past, but his brother Charles, I consider a friend and a colleague here in New Jersey. We've known each other for years and have worked on things together for years. The other thing I would say, it warmed my heart to know that he was the president of the Society for Clinical Vascular Surgery. My old professor, Dr. Bruce Brenner at Beth Israel in Newark, I believe was president of the same esteemed society at one time. And so that always holds a special place in my heart. Dr. Brenner taught me a great many things about vascular surgery. And it was a fascinating discussion today. Monica, you brought out some really great points. I think we could have gone on and on. And hopefully Professor Dietzek will accept our invitation. We didn't get to talk anything really about lymphedema today, but maybe he will accept our invitation to come and join us again sometime.
That would be great. I enjoyed this.
Before we go, does Jacqueline have a question or two she wanted to pop in? We haven't heard from her tonight. Jacqueline, anything?
No, I think you guys covered everything beautifully.
Okay.
The one thing I would say to Jacqueline is that based on one of Dr. Dietzek's observations, we saw the same thing. And Jacqueline, you might want to comment. There's no question that there are people with smaller saphenous systems who have rip-roaring reflux and are highly symptomatic. And then you'll see the patient with a gigantic vein and very little reflux and very little symptoms. So Jacqueline, you would agree that that's something we documented many times in our lab.
Oh yeah, I was thinking of the one woman who had the small saphenous, and it was maybe 0.23 centimeters, and she was completely symptomatic. And you closed it, and she was relieved. Do you remember who I'm talking about?
I
And
do.
she could pinpoint where her pain was. It was exactly at that spot.
Yeah, that's one of the things I was agreed. That was one of the things I was very incredulous about early on, that where these patients would point, it hurts right here, point, it hurts right there, and then it would be substantiated with ultrasound, and then with treatment, their symptoms would go away. So those are some fascinating questions that I think still need some answering in terms of the hemodynamics and the pathophysiology, why some people with huge veins appear to be completely asymptomatic and others with smaller veins can be, highly symptomatic. So
yeah, that is something that has really also plagued me for years, is the fact that you can see a 75-year-old man or woman, particularly men, that have huge varicose veins for 40 years, do not appear to have any of the sequelae of venous disease and are asymptomatic. I do not understand it.
The other thing,
there is even a French study done by Professor Carpentier who showed that actually, like in the beginning of the formation of varicose veins, you have much more symptomatic patients, especially for female patients, that after many decades of a life with varicose veins.
Interesting. Paul, you better get us out of here. We're going to get back into it.
Yeah, absolutely. We will continue for another hour.
It's actually so interesting. I wouldn't mind going on tonight a couple hours, but I know you guys have things to do, so we better go. You've been listening and watching to our LymphCast show, episode 25 tonight. Let's thank our panel. From Arizona, although from Miami tonight, Dr. Monica Gloviczki. First of all, thank you for everything, for bringing our guest in, for all of your input. And then if you would take a moment to thank our guest, we'd appreciate it.
Thank you very much. Thank you, Alan, or Professor Dietzek, for attending this show. That was absolutely wonderful. And, I think that your knowledge about all varicose vein procedures, certainly it's absolutely huge. and will help our audience to understand better what they should do with the varicose veins. So thank you on behalf of our team of LymphCast and on behalf of all patients who will listen us.
Thank you.
And of course, thank you very much, the team, for having me. And well, I'm looking forward for the next episode.
All right, very good. Thank you very much. From New York, RVT, Jacqueline Sasek. Jacqueline, thank you for everything tonight.
Thank you, Paul, and thank you, Dr. Dietzek. It was a pleasure meeting you.
Pleasure.
All right. And the founder, creator of this show, LymphCast, also the founder, creator of VitaSupport MD. They make Vein Formula 1000, Lymphatic Formula 1000. From New Jersey, physician surgeon, also the creator of this show, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
Thank you, Paul. A great program, especially this evening. And to the listeners who are patients, I think one of the take homes is do your homework, do your research, and really try to find a physician with experience like Professor Dietzek, who has many years of experience, and do your homework, because as he pointed out several times in tonight's show, there is unfortunately some abuse in our field, and typically that abuse is being done, I believe, by people who don't have proper training and credentials. So look for training, look for credentials, look for reviews from other patients, and use your best judgment and trust your gut instincts on those. And Professor Dietzek will give you the last word.
No, I really appreciate you having me on this program. It was really very interesting for me. I enjoyed it. And Paul, I enjoyed your voice, I got to tell you.
Okay. Thank you, sir. I appreciate that very much. I learn a lot every time. A very informative show tonight, not only for me, but for our listeners as well. And you've been watching and or listening to LymphCast episode 25. We'll see you next time, obviously, for episode 26. Until then, have a great night. We'll see you next time.